You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the Pre-Hospital Care podcast. I'm Lisa Burrell, and I'm joined today by a very special group of people to talk about the incredibly important topic of spontaneous coronary artery dissection, also known as SCAD. I have with me Sarah Coombs, who is trustee of the key patient support organisation Beat SCAD, Jerry Maroney, who herself experienced a life-threatening spontaneous coronary artery dissection, and Dr. Tom Keeble, who was the consultant cardiologist who led the team that recognised and treated Jerry at the time of her dissection so that she is here with us, healthy today. What a huge privilege it is for me to host this discussion today. Welcome to the podcast, Sarah, Jerry and Tom.
Hello.
Hello.
Hi, thanks.
Hi. So in this podcast, we're going to be exploring what a spontaneous coronary artery dissection is, some of the diagnostic overshadowing around it and why we might miss it, particularly in the pre-hospital environment, the real lived experience of SCAD, most importantly, and what we as clinicians can do for our patients of the future. So lots to get into today and a really powerful discussion, and I'm really, really privileged to be bringing it to you all today. So Jerry, maybe if we start with you, could you take us into this? Share with us your story, what happened, what you went through at the time, maybe what was important to you throughout your care, good or bad. Tell us what happened.
Yeah. So it was September 2021. They started normally. The world was just opening. If you remember, that was COVID time. The world was just starting to get back to some sense of normality. And we had delayed the baptism of my son so that we could have some family come visit and actually be with us, since they'd never seen him since he was born. So we had that the day before. It was fabulous. That morning, again, everything was normal. I was preparing to say goodbye to my family to get their flights off. They were with me having some brunch before they were heading off on their journey. Everyone was super happy. I was preparing something to eat, just a tea, and I'd eat something quite quickly as I was preparing it, and I had a real big coughing fit. Something felt like it just stuck in my throat. I was a new mum, I was winding a lot, and I thought, right, there's just something stuck there. So I asked my husband to wind me because it was a sharp pain, but nothing I would have thought was ever going to be catastrophic. So after a few more minutes, it started to just develop and started to really feel like something was lodged in my esophagus. And I was trying to continue on with what I was doing, and I thought, I started to feel dizzy, started to feel a bit nauseous. So I took myself off, pretended I had to go look after the baby, and I'd be back in 10 minutes. And I started to feel really uncomfortable. And I lay down and I had pain in my chest, in the centre of my chest and radiating. And I had neck pain, strong jaw pain, and pains going across my shoulder into both my left and my right arm. So in my mind, this was some form of digestive, and I was having a bit of a response to it. I also started vomiting, which again reinforced in me that this was going to be digestive because all those symptoms. And never once did I ever think this was an impending heart attack, because nobody like me on the TV has ever had a heart attack. And watching Holby City and Casualty when I was younger, people clench their chests and fall to the floor. That's not me. My husband came up to see me and asked if I was okay, and I explained what was happening. I explained that I had pains in my chest. I did have a pain in my left arm and right arm, and my jaw pain, and I just felt really unwell. And he's from the fire service, and he said, Jerry, I think you're having a heart attack. We need to get you to A&E. And I said, don't be stupid. I'm not having a heart attack. Do I look like someone's going to have a heart attack? This is COVID. I'm going to present with digestive problems. They're all going to think, what are you doing here? Please go home. That's just not possible. Also, I'd just given birth 5 months before. I managed that pain beautifully. How would I present myself with what I thought was potentially really bad digestive issues? So I said, I'll be fine. Go down into 10 people. I'll be down in 10 minutes. So the pain started to develop a lot more. I couldn't really speak, which should have been a sign because I like to speak quite a bit with my family. So I just had to sit there and observe. No one really noticed because they were all very, very happy, but I couldn't interact. I just had to manage myself through it. I thought they would be going home. It would be fine. I'd see them off. And then when everyone left, the pain started to build. It started to become a crushing pain in my chest. So I thought, well, I'll see how it goes. Again, the NHS is very, very busy. But then something just felt really wrong. And I thought, I'll phone 111 so they could tell me it was okay. And it was digestive. So when I called 111, they told me to go take aspirin and that I was likely having a heart attack and they'd send an ambulance. So I was absolutely shocked because still at that stage I was still in denial that was actually what could have been occurring. By this point I was really struggling. I was in a lot of pain and I couldn't really speak and my breathing was starting to become very difficult. So it was COVID. There was a bit of a wait with the ambulance. The ambulance crew arrived and lucky for me, they said, you know, you're in a lot of distress. All your key signs are normal. Your ECG is normal. Blood pressure is normal. They gave me GTN spray. That didn't do anything for the pain. It just made my head a little bit light. And luckily the very experienced paramedic says, you know, this is above my pay grade to make a life or death decision. We need to get you to the hospital. We can do a simple blood test and that will prove or disprove it. We could have missed the event. You could have had the heart attack and we just might have missed it. So let's get you off to the hospital and get you checked. And thank God he did, because that saved my life. Because I wouldn't even have got myself to the hospital. Meanwhile, my husband was looking at me as if, what did I say? So again, another really important factor, and I know this sounds so silly, but a really important factor from that paramedic said, you know, it is COVID. There's a really long wait. Take a charger and take some money to get a cab home, and hopefully, and your husband can look after the baby, and hopefully after everything, you'll be home in a few hours. And if he hadn't done that, I wouldn't have had a charger. I wouldn't have had any of the things. I wouldn't have prepared myself to make a really awful phone call that I had to make many hours later. So I'm very, very thankful for him because he saved my life, really. I would not have been in the right place if it wasn't for him. And he was curious to ask, something's not right. You don't fit the usual profile, but something isn't right. So he got me to the hospital. When I got there, it was a bit chaotic. It was COVID. And there was a number of tests, which, you know, was all a little bit of a blur at the time. But I remember my chest x-ray, my echocardiogram, everything was normal. And the doctor treating me at the time had said, well, I doubt it's a heart attack because you don't look like someone that has a heart attack. I suspect it's myocarditis because I had the COVID jab 2 weeks prior. And he said, usually we see it in males, but it does present in females, so it's likely going to be that. He also asked when I last took cocaine, which is extremely shocking, and I now know that is part of the practice. There is ways and means of asking that. I said, never taken drugs, and particularly not having a 5-month-old child at home. And he said, yeah, well, I definitely do think it's going to be myocarditis. So luckily for me, they did take blood tests. And after about an hour, alarms sort of went off and people rushed in. And then I was taken to resuscitation. That was all very traumatic and very much a blur because I had absolutely no idea what was going on. I roughly knew what myocarditis was, so why was I going here? And that bit was quite traumatic. After I became a bit more compos mentis, I asked the nurse what was going on and when can I go home and see my son. And she said, unfortunately, Miss Maroney, you've had a massive heart attack and are continuing to have one. And we think you might go into cardiac arrest, so this is why you're here with me. You need to make arrangements. You won't be going home anytime soon. My world collapsed. It just collapsed at that point. How on earth am I going to tell my husband I've had a heart attack and I'm in a resuscitation ward and him and my 5-month-old child at home? is at home and is mum coming home? So I just shut down and went into work mode. I absolutely just thought, this is a process I have to get through, and I just have to get out the other end of it. Now, that has caused lots of psychological trauma as a result, but I had to get me right. I had to get me focused. I had to get into an action plan, and I had to make the call to my husband. I waited a while because how do you say these things? So I told him what had happened. I didn't tell him I was in resuscitation at that time. I didn't think he needed to know that with a 5-month-old baby at home on his own. And I said that we'll get through it and it'll all be fine. I don't have any of the details yet, but I'm going to be here for a while. Can you start making arrangements? It was also very difficult and something that's formed part of my psychological therapy afterwards, is this was all done while I was on my own. It was COVID. Nobody could come and see me. Nobody could come and visit. I wasn't able to see my baby during it until much later in the time. And then after many, many hours, when I was a little bit more stable, they then tried to transfer me and get me a bed. And that's when I was able to try and talk to my husband a little bit more. And that's when I asked the nurse, could she explain what was going on a little more? Because I had absolutely no idea. And they said they didn't know why it was happening. I was a very rare case. But I was extremely ill. And this is going to require a lot of looking after for the next while. And to try and make arrangements at home. So then, after 3 days, once they got me a little bit more stable, I was transferred to get an angiogram done. And that's when I was transferred, Dr. Keeble, to undertake the angiogram. I was really broken. I was extremely broken by the time I arrived there. I was in a mess. I'm really tiny. I'm like 8 stone. I have childlike arms. Every vein had collapsed in my arms, where every time they tried to either take bloods or inject me and do various things, I was just a very broken, fragile individual. So when I arrived to see Dr. Keeble, another significant factor was he looked at me and he said, I think you have a rare condition called SCAD. And if I put this catheter inside of your heart, I could do irreparable damage. So I'm going to try and get you an MRI. We should be able to see if it's SCAD on the MRI, and then we'll take it from there. So I went to get the MRI done. It wasn't successful. They couldn't slow my heart down enough. The image was too blurry. I had a very difficult time with the staff in trying to get these things injected to me. And it was just really horrendous, and they were not very compassionate at the time. When we got the results, when I found that it didn't work, again, I was absolutely distressed and thought, well, we're going to have to go through some of this again. We then back up to Dr. Keeble. He said he would do the angiogram. A really important, compassionate piece from him, which you will never even remember, Tom, is I remember the anaesthetist asking how much I needed to be sedated. And he said, look, she's in a very bad way, so let's just put her right. And I can't really have her move. We also saw how tiny my arms were and how badly, just the veins were just in a bit of a mess and everything. So he said he wouldn't be able to get the catheter in my wrist anyway, so we went through my femoral artery to get it done. And I think that period was the first bit of tranquility that I had while he was doing that, because it just allowed me to zone out for a while. And when I came around, he said they confirmed it was SCAD in my circumflex artery, and that he would refer me to Dr. Al-Husseini, who was a specialist. He'd actually done his training in some of the SCAD from attending some of her sessions. He would refer me to her, and she would then take care of me and my care. And then that's where the rest of the sort of post-recovery begins. I was in hospital for 7 So just under 7 days. I did get to see my baby son on day 4. A huge amount of work had to go into doing that because the cardiac ward is not set up to have children visit. And also it was COVID. So we had to work around a lot to get that done. And once I was discharged, then I continued into just looking through what I need to do to get myself, my finances. If I was a chief wage earner, how am I going to make this work? Having a catastrophic illness, being a newborn baby, being on maternity leave, how do I make all this work and try and keep myself alive? And I'm sure we'll talk about it a little bit more after that, but the post-recovery is equally as traumatic as the event itself. And I think that's the thing that I'm keen for listeners to hear, and particularly for our fabulous cardiac specialists. The cardiac event is a moment in time which is life-changing and catastrophic. For us, it's the bits afterwards which also take a long time to deal with. So I'll hand it back to you. I'll stop there. Let's go off, Barbara.
Jerry, thank you. Yeah, first of all, thank you so much for sharing that with us, because that is so powerful. And those of us who are healthcare professionals actually often never get to really hear the impact that our care has for people. And what I really heard you describing there in the healthcare professionals who've made a massive difference to you was curiosity and compassion. And I just love how powerful those two things were for you, that the clinicians who really made the game-changing difference held on to that curiosity to understand what was going on for you. And you don't look like somebody who would have a heart problem. I understand why people were confused, because you don't fit the stereotypes, do you?
And that's one of the real difficulties of SCAD, and forms part of the psychological recovery. I didn't bring this on myself. I am fit, extremely healthy, very balanced diet. Yes, I work in a very stressful environment, but I was at the top of my game and I loved it. I never sit still. I get bored if I sit still. I did everything right. And that was one of the things in that hospital bed and continues afterwards. How on earth does this happen and why me? Because all the education, all the materials show a traditional atherosclerotic risk factors and lifestyle, which isn't me. So completely agree.
So I'd be really pleased to bring in Dr. Keeble at this point, because Jerry, every time we've spoken, you've talked about how it was his compassion in his care that really transformed things for you. So it's genuinely an honour, Dr. Keeble, to have you with us today, to talk through, if it's okay with you, just a little bit about you've got quite a lot of expertise now in this over your years of practice, and spontaneous coronary artery dissection isn't something that every clinician listening to this will even have heard of before, let alone understand what it might mean if they have a patient in front of them. Can you tell us a bit more from your clinical perspective? What is SCAD? And if you had the gold standard opportunity, how should it be treated? Why do you think health professionals might be missing it, and what can we start to be doing that would be better for patients?
Okay, well, look, thank you very much for the invitation. I trust you can hear me okay. So I think the first thing to say is that the reason that patients don't feel very well and why it mimics a heart attack is because essentially the same thing is happening to the heart as a heart attack. And what I mean by that is the heart is not being supplied with oxygenated blood. There is an interruption of the blood flow. Now, as you've heard before, most people who present with a heart attack are often male, often in their 50s or 60s, often smoke, have high cholesterol, diabetes, high blood pressure. That is the classical person that I see when I'm on call and I get called in to unblock a blocked artery of someone with a heart attack. Now, of course, Jerry does not fit that in any shape or form. In fact, completely the opposite. But her symptoms, and this is, I think, one of the most important things for your pre-hospital listeners, her symptoms were absolutely classical of a heart attack, to the point that her husband said it was a heart attack. So I think that's the key thing that the paramedics must learn here, or should take on board, is that the heart doesn't care why it hasn't got blood supply. It doesn't know the underlying etiology. It doesn't know why. It just knows it's not getting enough blood supply, and those symptoms will be the same regardless of the cause. And you know that in a young female, just had a baby with no risk factors, the most likely diagnosis is spontaneous coronary artery dissection all day. And that's what all of us will be petrified about. The reason why I say we're petrified about it is SCAD by definition is a tear in the artery. So rather than disrupting blood flow because it's got a clot in it and it's blocked and it's an atherosclerotic plaque which has got excited, a lipid bit of cholesterol that's got excited and got blocked, it's not that. Her arteries are nice and smooth. But what's happened for whatever reason is a small tear has happened in the artery. In that tear in the coronary artery, blood has gone into the tear and into the wall. And when that wall has got blood within it rather than in the lumen, it then compresses the normal artery and compresses the blood flow and prevents blood from getting to the heart muscle. She then gets chest pain. She doesn't like it at all, just like none of us would. This is a horrible feeling. It's impossible. There's often an impending doom. It's a really, really unpleasant feeling, any lack of blood supply to the heart muscle. So when the patient comes to us, and I think the reason why there has been much greater diagnosis and much greater sort of evaluation of this condition is that we now have a very, very established what we call primary angioplasty service. So basically my cath lab is open 24 hours a day, 7 days a week for patients with blocked arteries. And it doesn't matter if the artery is blocked because of a clot or if it's blocked because the artery is torn. The patient will come to my cath lab quickly and efficiently. The ambulance people will often, clearly not in this case, but the ambulance people will often bring the patient directly to the cath lab because they've got ST elevation on their ECG because there's a lack of blood supply. And so we then take patients, young like Jerry, to the cath lab and make that diagnosis in real time. And we can see that. And that's why I think there's more of an appreciation of it. Not only that, we are using what is called intracoronary imaging more often, where we put a little ultrasound probe or other probes down the artery and we can see the two lumens. We can see this tear and we can see this true lumen and this false lumen. So more often than not, we are getting the real true diagnosis rather than either pretending it's cholesterol buildup, which it's not, or missing the condition completely. So I think there is an increasing awareness of this. I think that, and I'll sort of finish on this final bit now. I think that, young, otherwise fit women with no normal risk factors, they do scare us slightly because all of us in the interventional world have had challenges. We described it with access. We go via the arm artery in 95% of our patients. Often with young ladies who have very small arteries and are very scared, we can't go up the arm artery or it's more challenging. And so we end up going in the leg artery, which has a slightly increased risk, but it allows us to get into the coronaries quickly and effectively and safely. So I think that this is also a very, what we would call heterogeneous group of patients. So some people come straight in with a heart attack. Some people grumble on at home for a day or two with on-off pain. Some people just go into cardiac arrest and come in as a cardiac arrest patient. There is huge heterogeneity, which depends on where the tear is, how big an area it's affecting. Is it just down the bottom of an artery and not causing a major bit of bother? Is it right at the very top of the artery, which obviously is much more high risk to us when we put our tubes into that artery? So I think that we're at a point in time where spontaneous coronary artery dissection is now known by most invasive cardiologists and most cardiologists as a whole. There is increasing research as to identifying and treating this, although we do not have the full picture. We are very good at treating standard heart attacks, and I would say less good at picking this up and treating this. We're also less good at the rehabilitation and the cardiac rehab side because we have less of these patients on our books and we don't have the research to know, well, which bits of cardiac rehab would they benefit from and which bits maybe are different. They don't need to lose weight generally. They don't need to treat their diabetes better. Blood pressure is important because if you have a tear, controlling your blood pressure is vital. So that remains important. But everything else is kind of, is less important as to cholesterol and atherosclerotic disease. And finally, I think when we treat a heart attack, generally, if you look after yourself and look after the risk factors really well, it probably won't happen again. I think the worry with SCAD is that you didn't know why it came in the first place, so why won't it happen again? And I think that is a very real concern that's very difficult for us as physicians and rehab nurses and teams to square off. Because with my cardiac heart attack patients, I can say, look, as long as everything's good, you're very unlikely to run into bother. With my SCAD patients, I can't look them in the eye and say that because I don't know. And we'll do our best. And we'll make sure their blood pressure's perfect, make sure, the things we can control are perfect, but there aren't many of those. And then it is, I'm afraid, sort of down to an element of, wait and see. But we do know there is a very real recurrence rate. And I think this is a real reason for further research. But if we can reassure and educate paramedics that if it looks like a heart attack, the ECG and the story, treat it as a heart attack. That's the key thing. It's not their problem as to why the blood supply is compromised. The diagnosis is important that the blood supply is compromised. And ambulance crews are extremely good at, if you like, identifying heart type pain and looking at ECGs to make a call. And we do a lot of education with that, and they're very good at it too. And they bring us most of our patients, 90% of the time. So I hope I haven't mumbled and rumbled too much around it there. But heart attacks are different, and we need to identify these patients early, and the heterogeneity makes life quite difficult for us, is what I would say.
That's brilliant. Yeah, there's so much in there, isn't there? And this is a bit of a challenge for us because it's breaking the mold of perhaps what we've traditionally been thought about heart attacks, and what we've traditionally had trained, what we've trained in, and what we've modelled in our minds about what we're treating in terms of we've trained quite well for atherosclerotic heart attacks. We know how to recognise STEMIs, and sometimes these patients are presenting in a different way. The ECG changes are there or they're not there, and we're just not familiar, or there isn't just that awareness hasn't rippled out into the pre-hospital world quite as much as it has across the cardiac intensive care unit. So the work that's going on to try to raise awareness is really powerful, I think, and so important, especially when you hear stories like Jerry's, where the curiosity, the recognition, the compassion to bring about the interventions, to diagnose and treat, is life-saving. So, it's really important that we're making progress with all of this. So, powerful. Thank you. And Sarah, I think this is probably the perfect time to bring you in, to flesh out some of that a little bit more for us. We're going to come on now. Well, first of all, actually, I'll ask you the same question that I asked Tom. What is SCAD and why are we missing it? But also, the organisation that you're working with, Beat SCAD, is a powerful leader in supporting patients. And maybe you could then take us on into what support is available for people.
Sure. I think possibly the best way to do that would be just to briefly share my story, because my SCAD story is a bit different from Jerry's. So 11 years ago, I had my SCAD heart attack completely out of the blue while driving my 6-year-old to a birthday party. And just as Tom mentioned, I had a premonition that something awful was about to happen, that impending sense of doom. And I made a split-second decision to turn my car around and drive us home. And I literally fell through my front door having my SCAD heart attack. An advanced care paramedic arrived, and even though I described clear cardiac symptoms, she decided I'd had a panic attack. And that's something I'd never experienced in my life up until that point. I knew something wasn't right. I had to insist on being taken to hospital, and I wasn't taken to a heart centre. I was taken to just a regular A&E. Luckily, bloods were taken, and there was great surprise from everyone when the diagnosis came back that I'd had a myocardial infarction. And like Jerry, the very first question I was asked was, when did I last take cocaine? And the answer was also never. I think I could so easily have stayed home. I could have been persuaded by my paramedic not to do anything about it. So I'm really glad I insisted on going to hospital. But unlike Jerry, my ECG was normal, and my eventual diagnosis was an end-STEMI heart attack caused by SCAD, and I didn't have a dissection flap. So the research is still ongoing, but from what I've understood from Dr. Adlam, based in Leicester, who's our lead clinical researcher in the UK, is that there is the micro blood vessels that supply blood to the artery itself. Something happens, and we're not exactly sure of the mechanism yet, but those micro blood vessels can leak and cause a bruise between the layers of the coronary artery wall. And that bruise can form a swelling, which then reduces the flow of blood through the central true lumen of the artery. And, in some cases, then that pressure becomes so great that there is a tear, and that can help equalize the blood pressure and the flow a little bit, but then the flap itself can become an issue. So there are many different kinds of SCAD as far as I understand. And that's why it's so important that we continue funding the research to try and find the answers. But back in 2014, SCAD was a mystery. I was query myocarditis. I was query pericarditis. It took a week to get a diagnosis. And the cardiologist who did my angiogram said, well, you're never going to meet another person like you, and don't worry, it'll never happen again. It'd be like getting struck by lightning twice. So, obviously I know now that those assertions aren't quite right. I'm very grateful for the fact I've not had another one. But back then, very much like Jerry, I had a 6-year-old, not a 5-month old, but it did take me a lot of desk research to find anybody who knew anything about SCAD. And after about a month, I actually tracked down Dr. Adlam. I found an email. I emailed him. He replied within about 24 hours, which is just mind-blowing, really. And he said, I know some patients. Would you like to be put in touch? And I was put in touch with a group of patients who eventually went on to create the charity Beat SCAD, which was launched in November 2015. And around the same time, a support group was also started on Facebook. Once I recovered sufficiently from my own SCAD, I started volunteering for the charity, and in 2018 I was invited to become a trustee. So I've been working for the charity ever since. So we're all about the provision of trusted information, access to experts, and the sharing of hope. We believe that knowledge equals power, and we encourage every single SCAD patient to get informed, learn to self-advocate. And then for our part, we raise awareness among the medical profession. We support patients and their families, and we raise vital funds to pay for essential research. And in fact, Beat SCAD paid for the funding that was behind the first genetic breakthrough discovery in SCAD research, which we're really, really proud about. So I think that's probably a good place for me to stop right now.
Sarah, thank you. And I can speak as a paramedic that when I hear you talk about being told that you were having a panic attack, it really does give me the chills and makes me think about every patient I might have said that to, particularly early on in my career. And goodness me, if there's people that I left at home that we just didn't understand at the time. I imagine everybody listening to this podcast at the moment is reflecting on people that they've had this exact conversation with, and my goodness, you're making us all think. So thank you. And I know that a lot of the work that you do is around education now, and it is really powerful. The best kind of education, in my view, is what we learn from our patients. So thank you.
Yeah, and having experienced panic attacks after my SCAD, having never had them before, I appreciate how difficult it is for first responders, because it took me a long time to work out the difference between proper heart pain and a panic attack that then developed cardiac symptoms. And like many SCAD patients, I went back to A&E 3 or 4 times in the first 6 months after my SCAD heart attack. So it's not an easy situation that paramedics find themselves in. But if somebody tells you they've never had a panic attack in their life and they're displaying cardiac symptoms, as Tom said earlier, I think it's all about treating the symptoms, not the perceived patient profile.
Yeah, absolutely.
That's right. I was just going to comment that the other thing that was so beautifully demonstrated was jaw pain. So jaw pain, unless you've got a tooth abscess, jaw pain is generally ischemic pain. So jaw pain, left arm pain, across the back and into your shoulders type pain with a tightness in the chest, all pretty classical. But the jaw pain, we do see it as well. I mean, this, as you know, is a more predominant female problem or challenge or medical challenge, and we do see, this jaw pain a lot in women presenting with this. The other thing, and I'm not wishing to confuse the diagnosis, but I think it is important for the pre-hospital teams listening to this, is that we're seeing more and more evidence, of course, of vasospasm, so spasm of the coronary arteries, and absolutely that can mimic heart attack too, and they are generally in young women with no risk factors. So I think the message is very clear from this webinar to the pre-hospital world. If you've got anybody with ischemic symptoms, it doesn't matter what the profile of the patient is, really. It's about the symptoms and it's about the ECG. And if the symptoms are consistent with ischemia and the ECG is consistent with ischemia, then regardless of the patient, it's up to then the cardiologist to work out what the cause of that lack of blood supply is. The diagnosis will all come together in time, but take it seriously. And as I say, panic attacks rarely happen unless people have got a history of panic attacks.
Yeah. And I think just something I'd like to add for the pre-hospital care providers is your approach as you hand over a patient at hospital can make a huge difference. We've got people in our community who report being handed over with words like, "This is a panic attack patient." Now, that sets the patient up to receive a different type of care. So, if you think something is not right, if something's not quite adding up, the way that you hand that patient over when you get to hospital can make a world of difference, not just to the care that the patient gets, but to how the patient themselves feels. If a patient's being told they're having a panic attack and then later on they find out they've had a heart attack, the patient finds it harder to trust their own gut for future, health needs. So I think, it cannot be underestimated how important a kind word, a gentle touch on the arm, "You'll be all right. We're going to take care of you. We're going to get you to a place of safety. We're going to make sure you get the care you need." It is life-changing.
I love that. Thank you, Sarah. And I think that's a really good challenge to give us all in a system that's currently so busy and people are being bounced from patient to patient to try to find out what's going on with each one. People are tired and all of that plays in. But to hold on to the reason why we joined the job in the first place, it was to be there alongside people, to make them feel safe, to make them feel that we were going to look after them, so that's really, really powerful to bring us back to that. So thank you. And maybe, Sarah, if I can just ask you a little bit more, what does it mean to you to be able to do the work of sharing the patient's voice amongst healthcare professionals and boost awareness? And, how have you been involved and seen the Beat SCAD organisation grow from its inception, the impact that it's had?
Yeah, I think, we're just about to celebrate our 10th birthday, and over the course of 10 years, we've learnt quite a lot. We work very closely with the researchers who support the SCAD community, and that collaborative relationship is absolutely vital. We support them by supporting the community. It reduces the number of queries they get from patients who are, once they're in the system, their clinical care system. But we can also support the research by helping with grant applications. We can put the patient case for why research needs to be done. We take part in the clinical trials. We help recruit patients for clinical trials, and we sit on the organising groups of research, providing our insight. So we're fundamentally knitted in to the development of SCAD research, which is a huge privilege. from the patient support side of view, we've done some adding up of the impact over the last 10 years, and we have literally distributed thousands of leaflets. There's something like 66,000 views on our YouTube channel now over the 10 years. We've educated going on for 500 healthcare professionals in training sessions, many of which I've done with you and your advanced care paramedics and the air ambulance simulation day we did last year. We support patients in an online community with 2,000 members. We've arranged one-to-one support via our buddy system for over 90 individuals. And without applying for grants, our community has raised and we have donated, over £425,000 to help fund SCAD research. And the number of SCAD research papers that have been produced in the last 10 years has grown exponentially as a result. So, we feel that we have a proper working relationship with the experts who are really integral to finding answers to the questions that Tom and every cardiologist has who comes across a SCAD patient. So it's an incredible privilege to support patients, to help them learn to self-advocate and to see them get better. And so many people, once they are better, then they say, right, I want to say thank you. What can I do? I'm going to raise money for the charity to help fund the research that we all need. So it's a really rewarding job to do. It's the best job I've ever done in my life, to be honest.
That's amazing. And so inspiring, actually, because this is how it should be, isn't it? Like, the patients can be partners of the future of our medicine and have that partnership with us to move things forward for everyone for the future. So that's really powerful to hear. And Jerry, maybe I could bring you back in at this point as well. What has being part of this community meant to you?
I honestly couldn't have got through these last 4 years without it. The first time of meeting Dr. Abby, she got it. She was an amazing professional, amazing cardiologist. She was a woman, not to take away from our male friends and colleagues. She was a woman with a young child. She knew, in my circumstance, what it meant to be a female in a very male-orientated world, to be the main breadwinner, to have to try and have a successful career and look after a young child. And then you throw in a catastrophic heart attack to that at an early age. So all SCADs are horrific, but a PSCAD, so pregnancy-related SCAD, is a little bit more horrific, and I would say that I had it because I have a tiny, tiny, tiny baby that I have to look after and look after myself. So being a new mom is incredibly difficult, first-time new mom, and then you have a major life-threatening condition. I had to get me right to be able to be around to look after my child. So she got that. And I think also, if it wasn't for her and explaining SCAD, I would not have done any of the things I should have done, or I must have done to survive, because everything I've ever done in life to get ahead and to get on is to put my head down and work bloody hard and get through it. And it was, I had to stop everything, I had to allow my heart time to relax so that the tear could really heal. You still have to be mobile, of course, and do your cardiac rehab, but you can't operate at 1,000 miles an hour like I did. I also had a lot of heart relaxants I had to take. But she also then shared that the physical recovery would take 12 to 18 months depending. But the psychological recovery is going to take much longer, particularly if someone's so young at the height of their life. And none of this was brought on by myself. And was she right? Because, as I said before, I just had to go into shutdown mode, just get through this, just get it done, try to get myself somewhat healthy. And I know the likes of Dr. Allen and others and many of the other great professionals, yes, if you are treated well, if you're taken to hospital well, your outcomes are normally very good and you can get back to normal. But it's a new normal. My life is not my was not my normal. I had to give up my career. I had to make significant financial changes to my life, and at a very, very, very early age, that I'd not saved enough for retirement, but yet my job in the city was incompatible with all the recommendations of SCAD. And to Tom's point previously, there is a recurrence rate. I didn't do anything to bring this on. So what's going to be different? Should there be another one? And if all of the recommendations is to minimize excessive emotional and physical stress, well, that's what I get paid for, is the stress. So I worked to achieve what I was hoping to achieve in my career, and I was almost there to have to step back. We've had to make significant changes, which, as I said, I wasn't anticipating ever having to make. And then only when I was able to get all of that wrapped up could I start my psychological recovery. And oh my God, did it hit like a ton of bricks. You know, and I'm 4 years down the line. I'm not there. I'm almost there at 5 stages of grief. You know, it's not linear. I've done the acceptance things, but every now and again, in big pivotal key moments of my life, I think, why? So I know the recurrence rate is approximately 10%. Sarah will keep me right on this. But though that is still too high a percentage that I could die. And I know death is rare. I know that. But if I don't get treated by people who will recognize my symptoms and get me to a place of safety quickly, I could die. Because I may miss, you know, it could be missed. So for me, that was just too much of a risk. And also, I couldn't give my organisation what they would be demanding of me. Real, you know, just very practical things. How can I be in board meetings and present when I have recurring chest pains that would take my breath away? And I'd have to manage myself, manage my anxiety. Is this one that's really going to be important? Do I need to get to an A&E? You know, try doing that on the web, on a conference call. It's real. So going back to the Beat SCAD work, I just could not have done this without them. Luckily, Dr. Abby put me in contact with Beat SCAD, particularly Sarah. There was a community where I no longer felt alone. This was just so rare, and how did it happen? You could ask all the safe questions. There was so much materials. The buddy system was fabulous. It allowed me to have a safe place to cry, to share my worries, to wonder if I'm going to be around to see my son grow up, what life's going to be like for me, you know, because I got such value from my career. And then who was I? Was I this broken person that is, you know, am I ever going to rebuild? So with all the help and support of the community, and a lot of psychological post-traumatic stress support, I have rebuilt my life. It is a great life. It's a very, very different life. But I am able to operate somewhat normally. My outcomes have been good because people have listened to me, but it's still quite different and quite tough. And I'm just so thankful for the Beat SCAD community because it's been life changing for me.
I wonder if I could just jump in. Something we haven't mentioned is that there is a nice guideline for acute coronary syndrome, and currently that is geared towards patients with atherosclerosis, which most SCAD patients don't have. So through lobbying, Beat SCAD was able to get a comment added in 2020 saying that the guideline was not appropriate for patients with spontaneous coronary artery dissection. But we still don't have an acute coronary syndrome guideline that is appropriate for us. And this is going to take clinical trials, which are underway, and the results will be coming in the coming years. But in the meantime, you know, after securing a diagnosis, which can be a bit of an odyssey for some patients, there's no standard protocol for managing SCAD. GPs have often never heard of it, and quite a few cardiologists still have a very simple understanding of it. Patients may not be put on the correct medications, may not be referred to cardiac rehab, and some even get told they haven't had a proper heart attack. So clearly this is something that needs to change. And as Jerry has so brilliantly explained just now. It's not just recovering physically, it's the psychological impact on the patient and the impact on their family. It can be huge. And that's before you start thinking about the financial and the professional impact. Getting back to work can be very difficult and maybe impossible. So we all have to live alongside the fact that we could have a recurrence, but it should be said that in the vast majority of cases, even people that do have a recurrence, and I know people who've had 4 or 5 SCADs now, they have done well. At the conference that we organised last week, we had one lady who's 72 now. She's had 3 SCADs since 2005, and she is still living life to the full. So, she is a great poster child for what is possible after SCAD. But, Jerry's story is so powerful for so many reasons, and we have to accept it's a spectrum. There will be people who can get back to living life pretty much as they did before, but there will be others who will have to take quite considerably difficult decisions about what they can and cannot do afterwards. And there are a small number of people in our community who are left with severely reduced heart function, people who have to take medical retirement and whose lives are never demonstrably the same again. They are very few in number, but they are there, and we want to get answers for them so that we can hopefully prevent this kind of damage being done to people's hearts long term.
Thank you, Sarah. I think I'm going to try to bring us all together now and bring this conversation into land a little bit and ask you all what are the positive messages that we can take away, particularly for the healthcare professionals who are listening to this. I mean, you've all touched on what's been pertinent to you about the behaviour of the healthcare professionals, the clinical diagnostics of those healthcare professionals. But if you had some takeaway messages, lasting bits of advice, I'd come to each of you and ask you what those would be. Maybe, Tom, I could ask you first.
Yeah, pretty straightforward from my side. I think we need to educate paramedics about the story of ischemia, the ECG, and to ignore what the underlying cause of the problem is, and we can sort that out later, but take the patient to an appropriate centre. Number 2, in the cardiac centre, and it will be predominantly cardiac centres that have this patients, we need to educate the doctors, the nurses, the physiologists, the radiographers, and everyone else in the catheter lab about this condition, so that we're all looking out for it in the catheter lab and sharing education. And finally, I think we need, and it is already being done, these patients do need, in my view, to be referred to expert centres in a sort of quaternary way, where they can be put into a registry, they can have further clinical trials, because we still don't know, as has been beautifully described already, exactly what the right treatment for the condition is. We've got some ideas and we've got some early data, but we still don't definitively know, and that this is a fairly heterogeneous group of patients, depending on cause and extent and any risk factors. So all of those things, but I think that Dave and Abby and SCAD have done a fantastic job setting up the registry, setting up these specialist areas, and I have no doubt in time this will improve because of that.
And to you, Jerry, what would be the takeaway messages that you would give to people?
I think education is really important, because where there's been education, it has worked. The paramedics, they were curious. He had life experience behind him. He got me to the hospital. Dr. Keeble, Dr. Abbey, with their expertise, they saw it, they were able to help and they were able to support. And in doing so, I'm very thankful for their humanity and compassion, because without it, I definitely wouldn't be here. And the wonderful Beat SCAD, they're all volunteers. None of this is paid. It is just the desire to bring education and some form of treatment and investigation to this area that helps glue us all together.
Yeah, it's powerful, and I think all your stories are going to stay with us. So Sarah, final thoughts from you to bring us to a close.
Yeah, I think you touched on it earlier, Lisa. I think if pre-hospital personnel are curious, if they listen to the patient, ask about recent life events around physical activity, psychological stresses, death, divorce, moving house, they've all been associated with SCAD heart attacks. Also interesting to ask people about stage of life with regards to menstruation. Fluctuating hormones are a known factor involved in many SCAD heart attacks. 90% of us are female, 10% of us are male. I think if we have a raised index of suspicion, if it's a patient with cardiac symptoms who doesn't look like a cardiac patient, don't take chances. Take them to a heart centre, get them a troponin blood test, and that way you can rule a heart attack out. And if so, happy days. And if it's a heart attack, then, as Tom said, you then know what you need to do to get the patient back to a stable condition.
Thank you. Such powerful messages for a really important life-threatening condition. So thank you for bringing all of that onto our radar more powerfully than perhaps we've ever heard it before. Sarah, thank you so much for the time that you've spent putting all of this together for us. Jerry, your story, what you've been through and sharing that so candidly with us today, and my huge privilege to bring you together with Tom again after the event that saved your life. So Tom, thank you for your time in the podcast today. It's been a huge privilege for me to have this conversation with you, and thank you for being with us today.
Thank you.
Thanks, Lisa. Thanks, everyone.
Pleasure. Thanks.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.